Here we go again, folks. Chapter 22, the second part, and that's all the respiratory system. Let's begin. This part two will be involved in discussing the dynamics of gas exchange. And the question here is, how do we breathe? We know that without our knowledge, we just take in air and we just release air, and um, it's actually something that we do on a regular basis. And when we hold our breath or we stop breathing, we can't do it. We just keep on doing the gas exchange as we need it. But pretty much why is it happening that way? Well, let's first of all let's take a look at uh, the term pulmonary ventilation. Well, pulmonary ventilation consists of two phases. First one is inspiration, which is where gases flow into the lungs, and expiration. And inspiration gases flow into the lungs, and expiration gases will exit the lungs. So, in this figure here, inspiration is the what do you call this? The flow of gas inside, and you're taking in fresh air, hopefully. And then expiration is actually when the air that is in your body is now ready to be exhaled out and released outside. So when gases exit the lungs, that's expiration. When gases flow into the lungs, that's inspiration. So let's take a look at some words again and figure out if we will understand this, because uh, the mechanics of breathing is not really a hard subject to understand, but you have to understand some prerequisites, some physics, some physical mechanisms or physics mechanism in order to understand how air is able to get in and out. Let's take a look at what is meant by all of this. Inspiration is an active process. Here, the diaphragm and the internal intercostal muscles would contract and would expand the rib cage. And when it expands the rib cage, there's going to be a change in atmospheric pressure. First of all, guys, the pressure in the atmosphere is brought about by air that is in the atmosphere. And the air is made up of three gases. You have the nitrogen gas, which accounts for about 78% of the gas that we inhale. And then there's oxygen, which accounts for about 21%. And then the carbon dioxide, which is minimal. It's about less than 3%. It cannot be any more than that. But the total percentage of all the gases, uh, the nitrogen, the oxygen, the carbon dioxide, and some other gases, is exerting pressure in the atmosphere that is equivalent to 760 millimeters of mercury pressure. When we inhale, we are inhaling air with a pressure that is equivalent to 760 millimeters of mercury pressure. When your diaphragm expands, it's pulling air out, and a change of volume inside it. It becomes low pressure inside. It sucks in the air from the outside, whether we like it or not. When our rib cage expand, when our this diaphragm here contracts, it flattens out, and then it uh, contributes to the volume of the lungs getting bigger. Then air gets to be sucked inside, because it creates a negative pressure here, and that negative pressure cannot be, because air or particles actually move from an area where there's actually too much of them towards an area where there is actually less of them. That's actually the law of nature. So our air is 760 millimeters of mercury pressure here. If this inside becomes less, about 756, something like that, or 758, air now will automatically flow from an area where there's too much of them towards an area where there's less of them. And there's no magic in it. It's just diffusion. And that's where you are inhaling. It's an active process. Why? Because the diaphragm and the internal intercostal muscles would need to work together and expand. On the other hand, the exhalation, where air moves out, is a passive process. The diaphragm and the internal intercostal muscle will relax. There's going to be an elastic recoil of the lungs from the pre-inspiratory volume. Uh, the atmospheric pressure, that one, is a pressure exerted by the air surrounding the body, and I mentioned that to you. At sea level, when you are at sea level, the atmosphere, which is equivalent to one atmosphere, you call it one atmosphere, is 760 millimeters of mercury pressure. Um, these respiratory pressures pretty much contribute to the atmospheric pressure. There's actually what you call relative uh, respiratory pressures that is actually being uh, that's actually supplied by the different gases that is found in the atmosphere. Now, negative respiratory pressure is any pressure that is less than one atmosphere. Positive respiratory pressure is a pressure that is greater than one atmosphere. And zero respiratory pressure simply means that the pressure outside and the pressure inside is equal, and therefore your lungs will not be moving, will not be taking in air. If there's no pressure gradient outside and inside your lungs, then your lungs will not be moving. We are not going to breathe at all. So right here it's showing us, and there are a few things that we need to know. It is showing us the atmospheric pressure that goes inside, which changes pressure inside, and this is actually this particular purple lavender colored area here is what you call the intra-alveolar pressure, and then this is actually the pressure inside your alveolus or alveoli. And then you have this light blue area here. This light blue area is called the intrapleural pressure. And that intrapleural pressure has only about 756 millimeter of mercury pressure, which is 4 millimeters less than 760, which happens to be the pressure in the atmosphere. Now, when the pressure in the atmosphere is 760 and inside is also 760 right here, we're not breathing. The pressure inside and outside are the same. Then your lungs would stay pretty much expanded. It is not going to collapse because of the negative pressure that is exerted by the intrapleural pressure. There it is, the negative pressure right here, and it keeps your lungs adhering. That negative pressure will keep the lining of your lungs close to the parietal pleura. The parietal pleura is actually cover, the cover of your parietal wall. The visceral pleura is actually the cover of the lungs. Between the visceral and the parietal pleura, you have a cavity, and that's your pleural cavity that is filled with a small amount of fluid. You cannot have large amount of fluid there. This particular intrapleural space is actually very small, and um, it's actually almost like touching one another. Touching this is actually almost touching there. There's very little space here that is filled with a little bit of fluid that is rich in hyaluronic acid, and you cannot have much fluid there or else your lungs will collapse. You will lose that negative pressure. That negative pressure needs to be maintained, and That can be maintained only if your lungs is actually like completely sealed, which means you will not have any holes or break in the pleura, in the visceral pleura of your lungs. That will keep your intrapleural pressure to be uh, negative. Okay, and when it is negative, your lungs is actually going to be expanded. So the intrapleural pressure, which is the pressure inside the pleural cavity, fluctuates with breathing. It is always negative pressure. It must always be negative pressure in order to keep your lungs expanded. When it becomes, when the pressure here in the intraalveolar and the pressure in the intrapleural pressure becomes the same, your lungs will collapse. So, in order to avoid the lungs from collapsing, you should maintain, or our body maintains, this intrapleural pressure to be 4 millimeters of mercury pressure less than the atmospheric pressure or the pressure inside the intraalveolar pressure. Now, I mentioned to you that the fluid level must be kept at a minimum because excess fluid will pretty much be hazardous to the integrity of the lungs. So any excess fluid is pumped out, constantly pumped out by the lymphatic system. If fluid accumulates in the intrapleural pressure, then the positive intrapleural pressure develops and the lungs will collapse. Now, there are two inward forces that will promote the collapse of the lungs. The first one is the natural tendency of the lungs to recoil. Your lungs always wants to recoil back, and that's because of its elasticity. The lungs always try to assume its smallest size. And then, of course, there's also what you call the surface tension of the alveolar fluid surface that is actually inside the alveolar sac, and it pulls all of those millions of alveoli into itself, trying to reduce the alveolar sac. And I will explain that later why you have surface tension inside the alveolar sac. So the mm, let me see. I think I did this. Okay. The intrapleural pressure. There's one outside, one outward force that tends to enlarge the lungs. And the elasticity of the chest pulls the thorax outward. And the negative pressure that is inside or in between that intrapleural pressure is actually what uh, is acting like an adhesive so that the walls of the lungs would stay up and connected with the pleural. So each time rather the parietal cavity. So each time the parietal cavity expands, whenever the muscles will lift it up, then the lungs will expand with it. It's like a strong adhesive force between the parietal and visceral pleura. And then, of course, you have your transpulmonary pressure. That guy there, that thing there, the pressure between the intrapulmonary pressure and the intrapleural pressure, like in between there, um, this pressure keeps the lung spaces open. It keeps also the lungs from collapsing. The transpulmonary pressure, I mentioned that to you. The transpulmonary pressure, that pressure right there, it keeps the lung spaces open and it keeps the lungs from collapsing. The greater, there's a generalization here. The greater the transpulmonary pressure, the larger the lungs will be. The lungs will collapse if the intrapulmonary pressure and the pressure in the alveolar becomes equal. If this gray area here and the pink area, the pressure in that gray area and the pink area becomes equal, then the lungs will collapse. And this can happen whenever, like as in this picture right here, there's a knife that's actually um, um, uh, put a you you actually like damage the lungs with the knife, that knife there, that will destroy the integrity of the lungs. The lungs is not anymore solid, and therefore the pressure, the negative pressure in the intrapulmonary area is going to be lost, and your lungs will collapse. You can have what you call a pneumothorax, or there's going to be air, and air develops in the pleural cavity. This is a pleural cavity, and it causes the intrapleural pressure to become equal with the intrapulmonary pressure. As a result, the lungs will actually collapse. So negative pressure, there's a rule of the thumb here. There must be negative pressure in the intrapulmonary space must be maintained to keep the lungs inflated. Atelectasis is a term that means collapse lung. It's a condition where the lungs will collapse, or the lung will collapse due to plugged bronchioles, which causes the collapse of the alveoli, or pneumothorax. This is actually your pneumothorax here, because of air in the pleural cavity. And this can occur from either a wound, right there, this is actually like what is showing here, a knife piercing right through creates that wound in the parietal pleura, or rupture of the visceral pleura because of a disorder. And it's treated, this can be treated by putting a chest tube and pulling the air out, sucking the air out through that, and pretty much creating again the negative pressure. And when the pleura heals up, the lungs will reinflate. So pulmonary ventilation. Pulmonary ventilation consists of inspiration and expiration. We are inspiring when the diaphragm contracts, it moves down, and your rib cage expands. The expiratory muscles will move, will contract and expand the rib cage. And pretty much the air is going to be sucked in. With the increase in volume, the air pressure here becomes lower. And when there's higher pressure outside, lesser pressure inside, then air moves from the higher into the lower pressure, right? So the changes in the volume in the thoracic cavity is actually what leads to the flow of gases to equalize the pressure. And pretty much this is brought about by this was explained by a scientist which brought about the Boyle's law. Boyle's law explained that there is a relationship between the pressure and the volume of gas. Gases will always fill the container that they are actually in. If the amount of gas is the same and the container size is reduced, the pressure will actually increase. So the pressure, according to Boyle's law, is inversely proportional with volume. Mathematically, you express it like this, and make sure that you know Boyle's law and the physics behind Boyle's law. Inspiration. Let's take a look at the when we inspire air, and you could see that when we inspire air, pretty much all the muscles are contracting. It's elevating the rib cage. It's an active process involving all of the inspiratory muscles. The inspiratory muscles, that is also the diaphragm and the external intercostals. These are the inspiratory muscles. They are active by contracting it. They expand the rib cage, lowering the pressure inside. Uh, so the intercostal muscle. which is actually pretty much your external intercostal. It will contract, the rib cage is lifted out, much like when your handle on a bucket is raised outward, it moves upward and increase the thoracic volume. As the thoracic cavity increases, the lungs are stretched and they are pulled out with thoracic cage. This causes the intrapulmonary pressure to drop by 1 millimeter only, millimeter of mercury pressure, and therefore the intrapulmonary pressure drops down versus the atmospheric pressure. When the atmospheric pressure is higher than the intrapulmonary pressure, then the air in the atmosphere moves in. The difference between the atmospheric and the intrapulmonary pressure makes the air flows down into the lungs. During the same period, the pretty much the intrapulmonary pressure lowers to about 6 millimeters of mercury, less than the atmospheric pressure. This will bring about forced inspiration, which can occur during vigorous exercise or in people with COPD. When you see people with COPD, you see them like almost like I'm sorry, I'm doing it inhaling air like with pressure or with force. Here, other muscles are actually needs to be activated. The muscles on the neck, the accessory muscles, the sternocleidomastoid, the scalenes, okay, and the pectoralis muscle right in this area here, it is not shown. They help in expanding the rib cage during vigorous exercise and during the breathing of a person with COPD. And because it is actually laborious breathing. The erector spinae muscle of the back is also helping to straighten up the thoracic curvature and act to further increase the thoracic cage size. Now, this would create a larger pressure gradient, so more air can actually drawn in. Now, although the principal working muscles are only your internal intercostals, it is still actively working on it. These accessory muscles would not actually play a role unless it is actually like a vigorous breathing, as well as in which is actually happening during exercise and when a person has COPD. Okay, on quiet breathing, expiration. Expiration is actually a passive process. Pretty much, it is a result of just the recoiling of the lungs and then relaxation of the muscle, which does not create any active energy. However, even in active breathing, whenever there is actually like active expiration, the internal intercostals pretty much will help pull the ribs down, and the abdominals, the rectus abdominis, the what do you call this? The muscles of the abdominal muscles will pretty much like pull the ribs down, and uh, there is a muscle behind which you call the quadratus lumborum. This also helps in pulling the ribs down and pretty much like decompressing the lungs so that your air is actually pumped out. Now, let's take a look at the changes in the thoracic volume and sequence of events during inspiration and expiration, which I pretty much already explained to you in the previous one. But this is actually in your textbook, and you will be reading this, and so I can explain to you how it works. So, um, during the process of inspiration, the inspiratory muscles will contract, the diaphragm will extend, and the rib cage will rise. You could see the diaphragm contracts, it pulls the diaphragm down, the rib cage will expand, and the ribs are also expanding and elevated by the inspiratory muscles. This is an active process. Now, this creates an increase in volume in the thoracic cavity, which eventually the lung would stretch the lungs, because the lungs are supposed to be like closely kneaded with the parietal wall of this rib cage. As the rib cage moves out, the lungs will also be stretched out, and that will reduce the volume, or rather the volume, that will expand the volume and reduce the pressure inside. The intrapulmonary pressure drops to about 1 millimeters of mercury pressure. That will invite the air to diffuse into your lungs. So the air flows into the lungs down to its pressure gradient until the intrapulmonary pressure becomes zero, or meaning equal to the atmospheric pressure. Expiration, just like what I mentioned to you, is a passive process. The inspiratory muscles will relax, the thoracic cavity volume decreases, the lungs recoil, the volume decrease causes the intrapulmonary pressure to increase by more than 1 millimeters of mercury pressure. So the air flows out the lungs down its pressure gradient also. So this is really good. Let me see if I can move it. Okay, now here you have a graphic representation of intrapulmonary and intrapleural pressure during inspiration and expiration. The intrapulmonary pressure is a pressure inside the lungs and decreases as the lung volume increases during inspiration. This is according to Boyle's law. Pressure is inversely proportional to the volume. Uh, the intrapleural pressure, which is actually the gray thing there, um, is pretty much in the pleural cavity. As in the pleural cavity pressure, the pleural cavity pressure becomes more negative. As it becomes more negative, the chest wall expands during inspiration, returning to initial value as the chest walls recoil. So the volume of the breath, this is actually the band for the volume of the breath. During each breath, the pressure gradients move from zero point 0.5 liter of air into and out of the lungs. So this is just a different representation. It's a graphic representation of the things that I explained to you. So non-respiratory air movements. This pertains to movement of air in and out of your lungs that is not related to breathing. And this could be when you are coughing, when you're laughing, crying, yawning, or hiccuping. So let's take a look at some factors uh, influencing pulmonary ventilation. There are three factors influencing the ease by which air passage and the amount of energy required for ventilation. And this will be your airway resistance, your alveolar surface tension, and lung compliance. Airway resistance is the opposition to airflow in the respiratory system, primarily affected by the diameter and the length of the airways. And tension, the alveolar surface tension, is tension acting as an inward pulling force that could potentially cause the alveoli to collapse, especially during exhalation. And I mentioned to you, I promised you that I'm going to explain this more. Lung compliance refers to the ability of the lungs to stretch and expand in response to changes in pressure. All of these are additional factors besides the gradient, the atmosphere, the gradient of the air pressure between the atmosphere and the lungs and the intrapulmonary space. These other physical factors would influence the way we are breathing. Resistance is the barrier presented to the air passage through the conducting pathways and has elements that is pretty much related to gas flow through the airways and tissues moving against each other. An increase in resistance is seen in obstructive airway diseases, but the fact remains that resistance in the respiratory tree is usually insignificant. Why? And well, because of two reasons. First, the diameter of the airway in the first part of the conducting zone, right in this area here, is actually like big. And the progressive branching after that of the bronchioles as they get smaller leads to an increase in total cross-sectional area, and therefore that will offset also the resistance. Any resistance that happens here occurs in the medium-sized bronchi, and resistance disappears pretty much almost all the way at the terminal bronchioles, where diffusion is already happening from the bronchi going into the respiratory bronchi and then the alveoli, which is actually what drives gas movement. So right here, uh, you can see the resistance right there, possibly in the trachea and in the bronchioles. This is an increasing resistance that could be brought about by obstructive disease that could narrow the airways. And um, this could actually happen during acute asthma attack, and pretty much eventually could stop even ventilation. And right here is actually when showing um, uh, what do you call this, a uh, the lungs that is not able or is actually being restricted from expanding. And it's because it's actually like experiencing reduced compliance. What is compliance? Compliance describes how easily expansion takes place for a given inflation pressure and involves both the lungs and the chest wall. It varies as the lung inflates. A decrease or a worsening in compliance occurs with restrictive lung diseases, as in idiopathic pulmonary fibrosis, where what do you call this? The alveolar sacs are going to be, or the cells of the alveolar sacs are being stimulated to produce a lot of collagen, and um, that will actually form a lot of scar tissue in the tissues of the lungs itself and preventing it from expanding, and therefore the compliance, so the lungs itself will refuse to comply, and that means it will have reduced compliance. uh, and so idiopathic pulmonary fibrosis is a restrictive disease. And this obstructive disease is actually the disease, like I mentioned to you, asthma is a obstructive disease. So now we're going to get into alveolar surface tension. Alveolar surface tension uh, is a significant force that influences the mechanics of breathing and the stability of these tiny air sacs in our lungs, which we actually call alveoli. The lining of the alveolar sacs, this lining right here, right there, okay, contains a thin layer of fluid, and this fluid is primarily H2O, water, which due to the high surface tension, you know that water itself, one of the properties of water is that it has high surface tension because water molecules are polar, and each water molecule are actually attracted to one another, pulling each other together, and this creates what you call a very strong cohesive force between the water molecule. They create a hydrogen bond, and that hydrogen bond creates the surface tension. This tension is acting as an inward pulling force that could potentially cause the alveoli to collapse, especially during exhalation. Now, our body produces a special type of protein which we call surfactant. It's actually looking like uh, actually it is by way of the properties it is like a detergent because has it likes both the lipid and the water portion of the body, and it helps reduce surface tension of the alveolar fluid and would prevent alveolar collapse. Surfactant is produced by the type 2 alveolar cells, and it helps us keep our lungs in good compliance and in an expanded mode, and prevents it from uh, collapsing. So we have here a homeostatic imbalance. We call this the neonatal respiratory distress syndrome. The neonates, most especially when there's a preemie, is actually a premature, is born like younger than 7 months. Uh, there is actually That's actually a very dangerous way to pretty much like get to the world. You're born at 6 months old, you're a preemie, your lungs does not have the ability to produce that surfactant yet, and your lungs will collapse. Um, this insufficient quantity of surfactant in premature infants cause what you call the infant respiratory distress syndrome. Now, an increased surface tension results in the collapse of the alveoli after each breath. The alveoli must be completely reinflated during its inspiration. And it will not happen, the reinflation is not going to happen without the surfactant. And this is actually common in premature babies. So how do they handle this respiratory distress syndrome in premature babies? Well, they put babies, the suffering babies, in in a tent, okay, and pretty much they will have mists of surfactant, and the baby can inhale the surfactant, and pretty much that's going to help the baby breathe. So, lung compliance is a measure of change in lung volume that occurs at a given change in the transpulmonary pressure. It is the measure of how much strength the lung would have. It is normally high because of the distensibility of lung tissue and the presence of surfactants, which decreases alveolar surface tension. A higher lung compliance means it is easier to expand the lungs. Compliance will be diminished or can be diminished by a scar tissue, as in the fibrosis, or reduced production of the lungs, as in the infant respiratory disease syndrome, and decreased flexibility of the rib cage, as in an aging person develops ossification of the costal cartilages, or um, some other what do you call it, some other diseases that brings about deformities in the thorax. These will actually decrease these things decrease the natural resistance of the lungs and diminishes what you call lung compliance, and it causes chronic inflammation or infection, such as uh, the, as in like diseases like tuberculosis. It can cause a non-elastic scar tissue to replace the normal lung tissue. So the lower the lung compliance, the more energy is going to be needed to breathe. That's why you see a lot of those people uh, walking around with oxygen tanks, they seem to be still having a hard time breathing and expanding their rib cage because they have poor compliance. So, when we are sick in the lungs, we go to the doctor. How does the doctor find out uh, our ventilation, or how is ventilation clinically assessed? Well, assessing ventilation involves evaluating the effectiveness of air movement, whether in a respiratory system or a workspace air exchange, and can be done through various methods, including visual observation or listening for clear breathing sounds, or utilizing equipment like spirometers, anemometers, and carbon dioxide monitors. Spirometers, as in right here, the test is spirometry. It's used to, well, a long time ago, used to be really a very uh, cumbersome clinical tool that's used to measure the patient's respiratory volume. But now is replaced by electronic measuring devices that is quite easy to handle, and they can actually uh, spirometry can actually read or give us um, a good look at our respiratory volumes. Respiratory volumes can be used. The moment that we get them, respiratory volumes can be used to assess respiratory status. Respiratory volumes can be combined to calculate respiratory capacities, which can give information on a person's respiratory status. Respiratory volumes and capacities are usually abnormal in people with pulmonary disorders. A spirometer uh, pretty much is now a good what do you call this is now a good device. It has been improved for several decades of improvement. It has now really improved. It's a valuable electronic measuring device used today to measure the or assessing ventilation itself. So this is our respiratory volumes, which you must understand and you must try to memorize what it means. First of all, the tidal volume, because this is actually how a spirometer would pretty much like uh, um, show, a graph will show when you're actually breathing in and out air. Unfortunately, we're not going to be able to do this in the lab, but you are not going to be personally doing this in the lab. This is what you miss because you are learning this online, but you're able to pretty much like know how it is by doing some interactive online things that we have like PhysioX and everything. So let's take a look at what the tidal volume is. What is a tidal volume? It says it's the amount of air moved into and out of the lung with its regular breath. So the regular breathing that you're actually doing, which averages about 500 ml of air per breath, is actually called the tidal volume. Then you have your inspiratory reserve volume, is the amount of air that can be inspired forcibly, forcibly beyond the tidal volume. And the inspiratory reserve volume is approximately 2100 to 3200. So your 2100 to 3200, this is actually your inspiratory reserve volume right in this section here. So it's the amount of air that you can inspire, that you have the ability to inspire beyond your tidal volume. Then you have your expiratory reserve volume. It's the amount of air that can be forcibly expelled from your lungs, which is about 1,000 to 1,200 ml of air. And this is actually your expiratory, expiratory reserve volume. When you're breathing out all the way and push yourself from breathing out, the total amount of air that you can forcibly get out of your lungs is actually your expiratory reserve volume. Then you have that green section right there, which is your residual volume. It's the amount of air that always remains in the lungs and is needed to keep the alveoli open. How do you, when we are not breathing, can you remove your respiratory volume? Can you fill it with something? Well, the only time that the lungs will lose its residual volume, rather its residual volume, is when you drown. You know that uh, mostly in part a lot of the when water gets into your lungs, then part of your residual volume, not all, no, but a significant part of your residual volume gets replaced with water. So respiratory capacities represents the total volume of air in the lungs at different phases of the breathing cycle, combining various lung volumes. These measurements provide insights into the health and can be used to diagnose and monitor respiratory conditions, and is a combination of two or more respiratory volume. For instance, the combinations of two or more respiratory volumes. For instance, capacity, your inspiratory capacity right there, okay, is the sum of the of the tidal volume plus the inspiratory reserve. So this part here, from the tidal volume all the way to the inspiratory, is your inspiratory capacity. You have the capacity. This is your total capacity to get the air in. That is your inspiratory capacity. Your functional residual capacity, FRC, is the sum of the residual volume and the expiratory reserve volume. So these two will be your functional residual capacity. And then your vital capacity will be everything else from your inspiratory reserve volume plus your tidal volume plus your expiratory reserve volume. All of this will be your vital capacity. Now, the total lung capacity is the sum of all the lung volumes. That means this is your inspiratory reserve plus your tidal volume plus the expiratory reserve volume plus the residual volume. In the lab, you are actually going to get into mathematically, you're going to look at probably what the inspiratory volume of a person, if its vital capacity is actually 6,000 and its tidal volume is 500 and its expiratory reserve volume uh, is about 1,200 and its residual volume is 1,200. What would be its inspiratory reserve volume? So you're going to do the math on that and you're going to learn it in the lab. Dead space. Do we have a dead space? Dead space can be the anatomical dead space. It refers to the structures that does not contribute to gas exchange. Consists of the air that remains in the passageways. About 150 ml out of the tidal volume is actually dead space. Uh, there's also what you call the functional dead space. You have also the alveolar dead space. The mentioned to you, what I mentioned to you is actually the tracheobronchial. The functional dead space is the space occupied by non-functional alveoli and can be due to collapse or any form of obstruction. The total dead space is the sum of the anatomical and the alveolar dead space. So, spirometry can distinguish between obstructive and pulmonary and restrictive diseases. And pretty much a measure of the pulmonary of lung capacities will tell the doctor pretty much if the person has an obstructive disease or a restrictive disease. Okay, for instance, if there's an increased airway resistance, for instance, in bronchitis, it says there bronchitis, there's an uh, the type the TLC, the FRC, and the RV might increase because of hyperinflation of the lungs. And that's actually very typical of the obstructive disease. In the restrictive disease, the TLC, the total lung capacity, TLC, due to disease such as tuberculosis or exposure to, let's say, environmental agents, or maybe fibrosis, the VC, the the vital capacity, uh, the total lung capacity, the the VC, the TLC, the FRC, the RV will decline because lung expansion is actually compromised. You could see here that lung expansion in restrictive disease is actually reduced, and therefore this is actually uh, the VC, the TLC, the FRC, and the VC declines because the lungs cannot actually expand, it cannot comply. So you have pulmonary function tests. These can measure the rate of gas movement, the forced vital capacity, which is the amount of gas that's forcibly expelled after taking a deep breath, and the forced expiratory volume, which is the amount of gas expelled uh, during specific time interval of the forced vital capacity. Pretty much, this FEV is a factor of the um, amount of the air in uh, expelled by this one. Healthy individuals can expel 80% of FVC in the first, and then patients with obstructive diseases exhale less than 80% in the first second. Whereas those with restrictive disease exhale 80% or more, even with reduced FVC. Unfortunately, this is something that we cannot also you do in the lab, but you are required to at least know what this type of pulmonary function or the importance of this type of pulmonary. So, in a nutshell, gas exchange occurs between the lungs and the blood, as well as the blood and the tissues. External respiration is a diffusion of gases between the blood and the lungs. And internal respiration, on the other hand, is a diffusion of gases between the blood and the tissues. Both processes are subject to the basic properties of gases and composition of the alveolar gas. So, let's look at your diagram here. This is your external respiration, the bulk flow of air into and out of the lungs. And that pink covering right there is actually your capillary, and this is actually your alveolar sac. It is showing you the exchange of gas from the capillary and the alveolar sac. Meanwhile, the second one, which is actually called internal respiration, is the exchange of gas between the capillary and the body tissues. So you have here the tissues, those are the cells of the tissues, and you have the capillary. An exchange of gas here where oxygen is delivered here, showing delivered here into the capillary, and carbon dioxide, and pretty much this exchange has also or is actually working in terms of concentration gradient only. If there's too much carbon dioxide in the tissue, that needs to be eliminated. So it goes and it gets picked up by the blood. If the tissue needs oxygen, the oxygen is also going to be coming from the blood and is going to be delivered into the tissue. That works also, and it moves because of concentration gradient. Now, the flow of air from the external environment, from the outside, happens due to pressure changes in the lungs. The alveolar gas exchange pretty much happens because of the surface area of the alveolar sac, the partial pressure gradient of the gases, whichever is actually more can actually get into our body more. But more is not just being enough. Like, for instance, your nitrogen, 78.5% of the air is nitrogen, but yet we don't really breathe in nitrogen. So, besides the partial pressure of gases, the solubility of the different gases in the air in the water also plays a vital role, regardless of how much air there is outside. If it's not soluble, it's not going to be mixing with the blood. And then, of course, in order for everything to really work well, there should be matching of ventilation and perfusion, which we'll be discussing later on. So first, in order to continue and understand the flow of gas and the exchange of gas also, we'll have to look at some properties of the physics of the pressure of gas in the atmosphere. According to Dalton's law of partial pressures, the total pressure exerted by a mixture of gases is equal to the sum of pressures exerted by each gas. The partial pressure is the pressure exerted by each gas in a mixture and is directly proportional to its percentage in the mixture. For instance, our total atmospheric pressure is 760 millimeters of mercury. Nitrogen, there's your nitrogen right there. Nitrogen exerts 593 millimeters of mercury pressure. The total pressure of all three is 760 millimeters of mercury pressure. Nitrogen alone accounts for 593 millimeters of mercury pressure. This means nitrogen accounts for about 78.6% of air. And therefore, that's what you call nitrogen is that's actually what you call the partial pressure of nitrogen. 78.6% of the air is nitrogen. You can calculate this by multiplying this 78.6% by 760 millimeters of pressure, and it will equal to almost that one there, 500, between 593 to 597. Oxygen accounts for about 20.9% of air or 21% of air. So the partial pressure of oxygen is about 159 millimeters of mercury pressure. Air also contains about 0.04% of carbon dioxide. And the carbon dioxide is not shown here because it's really minimal. It's very, very little. It also has about 0.5% water vapor and insignificant amounts of other gases that also pretty much like uh, contribute to the pressure of the atmosphere. At high altitudes, the partial pressure declines because the air becomes less dense. But at lower altitude, underwater, I meant, not sea level, underwater, the partial pressure would increase significantly. The pressure that we're talking about here, 760 millimeters of mercury pressure, is the pressure at sea level. So when you understand the partial pressure, this is actually the pressure of um, the gases that you find in the atmosphere. There's another law, which is called Henry's law, which is for gas mixtures that are in contact with liquids, its gas will dissolve in the liquid in proportion to its partial pressure. And at equilibrium, the partial pressure in the two phases will be equal. The amount of each gas dissolved depends on the solubility itself. And pretty much if you're talking about the partial pressure, if nitrogen has the greatest partial pressure, 78% of the air is nitrogen, and oxygen has 21 only. How come we breathe in the oxygen? We're always saying breathe in oxygen. We never even mention of breathing in nitrogen under air, under normal, what do you call this, under normal at sea level. Why? Why? Because nitrogen is not soluble in water. So it's not soluble in the alveolar water. It doesn't get delivered into right through the lungs and into our blood. It never. It it escapes out. The only one that gets delivered is that part of the atmosphere, the atmospheric gases that is soluble in water that we can actually pick up, and that will be your oxygen and carbon dioxide. Nitrogen won't come in, not unless nitrogen can. I'm not saying at sea level it won't. I'm not saying it will never come into our body. No, because nitrogen can come into our body when the pressure, when there's actually pressure that's going to push it into to become into to get in solution with the water portion of our blood, then it will, and we can pick it up. And pretty much this happens when we are actually swimming in deep water, where the pressure of water is actually, the pressure of air gets to be higher. And if you have heard of the word the bends, this is actually about nitrogen gas, which is the least water soluble among the air gases and does not dissolve in our blood when we breathe. When deep sea diving, the solubility of nitrogen in water increases as the divers swim into deeper waters. Because of the increased water pressure in the deep, then nitrogen gets to be soluble in our blood. Hence, we end up breathing nitrogen in the deep. Uh, Now, we want to breathe it out after diving. We want to breathe this nitrogen out because it's going to stay in our blood, and we don't want that foreign gas to be staying in our blood. It can cause a lot of problems. And we can do that by regulating our speed as we swim back on the surface. It will help the body get rid of the nitrogen gas that we breathe in. And when divers do not descend slow as should be, the nitrogen toxicity will happen, and this is called the bends. In the same way, breathing oxygen gas at 2 atmosphere, if instead of 1 atmosphere you breathe oxygen at atmosphere, that's really heavy, which means if you're actually down there and the atmosphere is actually in the deep, is actually atmospheric pressure is 2, that's going to be a lot of oxygen that you're actually getting in. But it is not as big as problem because oxygen is a natural gas that is actually part of our body. But it cannot be too much. You cannot actually breathe in too much oxygen. A higher concentration of oxygen is also toxic for us. Uh, it can actually develop we can actually develop toxicity to oxygen when the oxygen that we have taken in is greater than about 2.5 to 3 atmosphere. The atmospheric pressure is that much. we can develop oxygen toxicity. Excessively high oxygen concentration generates a huge amount of harmful free radicals. It results in central nervous system disturbances, coma, and even death. So, right here is a very good picture of how pretty much like gas is actually exchanged in our entire body. The alveoli contains more carbon dioxide and water vapor than atmospheric air because exchanges in the lungs where oxygen diffuses out of the lungs and carbon dioxide diffuses into the lungs. Humidification of air by conducting passages happens whenever the alveolar gases mix with each breath. The newly inspired air mixes with the newly inspired air mixes with air that is left in the passageway between breath. Now, in external respiration, let me see the external respiration here. Maybe I should just get it, explain it my way. Okay. Do I want to explain this my way or do I want to read this thing here and explain it to you as I read? Okay, in external respiration, it involves the exchange of oxygen and carbon dioxide across the uh, respiratory membranes. And this gas exchange is influenced by partial pressure gradients and gas solubilities. Now, we know that uh, among all of the three gases, nitrogen, carbon dioxide, and oxygen, nitrogen is the least soluble, and we are not even talking or discussing about entry of nitrogen in our system at sea level. But between carbon dioxide and air and oxygen, the one that is a more soluble gas is actually carbon dioxide. Carbon dioxide has greater solubility in water than oxygen. And it is it is good. That's going to prevent pretty much like uh, oxygen toxicity. We don't want too much of the oxygen. We just want the oxygen to be the right amount of oxygen. But carbon dioxide is really tragically the most soluble in water, and a dangerous increase in carbon dioxide in the air can dramatically also we can actually dramatically take it in instead of carbon dioxide being released out in the atmosphere. If there is um, a, a high concentration of carbon dioxide outside, you're not going to be able to exhale out your carbon dioxide because these gases actually move through our airway systems only by way of diffusion. Let's take a look at this in external respiration right here. You bring your you bring up your blood from the systemic tissues. You bring up your blood back into the heart, and then the heart pumps it into the lungs. Here, the moving blood will carry about 40 millimeters of mercury pressure of oxygen and pretty much like 45 millimeters of mercury pressure of carbon dioxide. Now that particular pressure of gases now it's going to be moved in the alveolar sacs. And right here, your 40 and 45 will actually create a gradient between the alveoli and the external environment. Now, the inspired air, when you take in air, the inspired air is about 160 millimeters of mercury pressure, and the carbon dioxide is only zero point 0.3. So, between 40 oxygen and 160 oxygen, oxygen from the air moves into the lungs much faster. And it's because you have higher concentration of oxygen outside and lower concentration of oxygen inside. Meanwhile, your carbon dioxide has zero point 0.3 millimeters of mercury pressure only outside, while there's actually like in carbon dioxide inside our tissues is 40 millimeters of mercury. So you are easily exhaling out the no the carbon dioxide is actually 45 millimeters. So you are easily exhaling out the carbon dioxide between 45 millimeters and zero point 0.3 millimeters of mercury pressure. You easily are exhaling out your carbon dioxide. So the movement of gases between the atmosphere and the alveoli is not going to be a guesswork. It is really easy. This is just by way of diffusion. In the same token, when you have when now you, when all of the gases have already been mixed, the alveolar lungs now, as it moves back into the tissues, will now be carrying 100 millimeters of mercury pressure of oxygen and um, about 40 millimeters of mercury pressure of carbon dioxide. So it goes back here into the tissues, and it will be releasing that 100 millimeter of mercury pressure versus the tissue pressure of the oxygen, which is 40 millimeter. That particular oxygen there is going to be delivered into the tissues. And your carbon dioxide, which is 40 millimeters of mercury pressure, as opposed to the carbon dioxide here in the tissues, which is 45, then you are actually going to release the one from the tissues back into the back into the back into the blood. We are going to be continuing to understand and to look at these differences in pressure and the movements of gas when we get into the exchange of gas between the capillaries in the next chapter in the um, no, we did already. We did already this one. We did this um, when we studied the movement of gases and solutes, uh, substances across the capillary. We know that they are not being moved by active transport. They're only being moved by gas uh, exchange, rather by changes in the concentration gradient. All of these different types of gas. So there's no magic trick on it. A gas that is in a particular area that would have higher concentration will move towards an area where there's less of them. And it happens in both cases because they're actually like traveling through and crossing a semi-permeable membrane. All of our gases can actually go through the semi-permeable membrane, and therefore the diffusion is actually easier for both of them. Let's take a look at respiratory membrane. Respiratory membrane is actually the cross section, the membrane that makes up the cross section between a capillary and the alveoli. So this is your alveolar sac right here. And your respiratory membrane is that membrane here. That membrane also there, you have a capillary and the respiratory. And then here, you have a respiratory membrane there. And then here and there. So the more capillaries you have in your alveolar sac, the greater will be your respiratory membrane. They are very thin. That membrane right there, there's an enlarged view of that respiratory membrane. It's very thin. It's about zero point 0.5 to 1 micron thick and has a large total surface area. Pretty much the alveoli alone, the total alveoli um, in our body or in our lungs is 40 times the surface area of the skin. That's really a lot of surface area. And the effective thickness of the respiratory membrane increases dramatically, sad to say, if the lungs become waterlogged and edematous, as seen in pneumonia or probably in left heart failure. The The about 0.75 seconds that the red blood cells spend in transit through the pulmonary capillaries may not be enough for adequate gas exchange. And the result of this, the body tissues suffer from oxygen deprivation. Now, certain pulmonary diseases drastically reduce the alveolar surface area. For instance, emphysema. The walls of adjacent alveolar break down, the alveolar chambers will enlarge. Also, tumors, mucus or inflammatory material can also reduce the surface area by blocking gas flow into the alveolar sac. So, the surface area of your respiratory, the alveolar, is actually very, very important because this is actually where your capillaries are actually spending their time to help in a gas exchange. And the more capillaries you have, the more respiratory membrane you have, and that's actually the site of all the gas exchanges. Just a picture of a normal lungs, which has really a good amount of alveolar sac, and the lungs with emphysema. Okay, very good. So now let's take a look at another something else, another that would pretty much like help us understand the dynamics of respiration, which is ventilation, perfusion, coupling. Hmm, what is this? Perfusion, first of all. Perfusion is blood flow reaching the alveoli. So perfusion has something to do with the blood flowing, reaching the alveoli. Ventilation, on the other hand, is the amount of gas reaching the alveoli. So ventilation and perfusion rates or speed must be matched for optimal, efficient gas exchange. Both are controlled by local autoregulatory mechanism. Your uh, the pressure or the availability of oxygen controls perfusion by changing the arteriolar diameter, while the availability of carbon dioxide controls ventilation by changing the bronchiolar diameter. Let me say that again. Let me repeat that because this is very important. The availability of oxygen controls perfusion by changing the arteriolar diameter, which means the availability of oxygen controls perfusion of oxygen in the blood, because perfusion is actually the uh, mechanism by which blood flows reaching uh, the alveoli. So it's got something to do with the blood carrying oxygen flowing into the alveoli, while ventilation has got something to do with the gas that is reaching the alveoli. Um, Changes in the oxygen pressure in the alveoli can cause changes in the diameters of the arterioles. This means when the alveolar oxygen is high, arterioles dilate, and where the alveolar oxygen is low, arterioles constrict. These will direct blood to go to the alveoli where oxygen is high, so blood can pick up more oxygen. The opposite mechanism is seen in systemic arterioles that dilate when the oxygen is low and constrict when it is high. The influence of local carbon dioxide on perfusion is that when there's actually changes in availability of carbon dioxide in the alveoli, there should be also, it can cause changes in the diameters of the bronchioles. Here's a generalization. When the alveolar carbon dioxide is high, the bronchioles will dilate, and where the alveolar carbon dioxide is low, bronchioles will constrict, which allows elimination of carbon dioxide more rapidly. Balancing your ventilation and perfusion pretty much is very important. Changing the diameters of local arterioles and bronchioles will need to be synchronized together with uh, the perfusion. So if your ventilation perfusion is not balanced, um, then your gas exchange dynamics is going to be screwed up. There may be regional variations that may be present due to the effect of gravity on blood and air inflow. That can cause a screw up of your ventilation perfusion. Occasionally, alveolar ducts plugged with mucus cause unventilated area. So, in short, uh, their ventilation or the amount of air that flows into the alveoli must match the perfusion, the amount of blood that goes into the alveoli. Because if that's not going to be like if that's not going to be matched up, then if your blood is very slow in flowing, no matter how much you breathe, your blood will not be able to pick up the gas that you need. So when you're actually breathing fast, your blood should also be flowing fast. So the amount of air that is actually being given to the alveoli is evenly matched and picked up by the blood as fast as it's coming. Now let's take a look at the case of internal respiration, the partial pressure gradient promoting movement of gas in the body. In internal respiration, that is actually the exchange of gas between the blood and the tissues. In the case of internal respiration, changes in the amount of oxygen in the alveoli causes changes in the diameters of the arteriole. Where alveolar oxygen is high, arterioles will dilate. Where alveolar oxygen is low, the arterioles will constrict and direct blood to go to the alveoli. Where oxygen is high, so pretty much at that time when oxygen is high, blood can pick up more oxygen. The opposite mechanism is seen in arterioles that dilate when oxygen is low and constrict when it is actually high. Whoops. Pretty much, guys. That that's the end of our discussion on this particular second part of the respiratory dynamics. We'll see you on the third.